Right. So we'll start now since uh, no one else seems to be joining. Right. So I'm Dr. Seniru. I'm a specialist in internal medicine, and I thought of bringing this class to you today on acute kidney injury because I chose this topic because it's quite an interesting topic and a topic that some students find difficult to understand and difficult to deal. And also, when you pass your exams and become intern house officers, this is a common clinical problem that we encounter. So it's important to know the basics of acute kidney injury and how to manage patients with acute kidney injury uh, from the exam point of view as well as from your practice point of view. Right. So, right. So during this talk, I'll try to be brief as possible. Uh, we'll have a discussion on what's the definition of acute kidney injury is and the staging of acute kidney injury, the types of acute kidney injury, namely pre-renal, renal, and post-renal, how to identify and manage patients with acute kidney injury, and what are the indications for renal replacement therapy in acute kidney injury. Right. So, acute kidney injury is the term that we use now for patients who are having abrupt decreases in their kidney function. Earlier, we used to call these patients as having acute renal failure, but even patients with uh, subtle impairments in their renal function can have significant morbidity and mortality, and hence these patients will be called as acute kidney injury collectively. Whereas failure would mean that the organ function has completely stopped. Hence, we have moved away from the definition or the labeling these patients as acute renal failure and labeling them more as acute kidney injury. So, when do you call a patient as having acute kidney injury? So, as you can see here, there are three bullet points, right? So, we have a marker called serum creatinine. If you remember from your physiology days, creatinine is used as a surrogate marker of the glomerular filtration rate. There are better markers of glomerular filtration rate like inulin, but creatinine is the one that is most commonly available and widely used. Creatinine is filtered from the kidney as well as it can be actively secreted. So, based on the creatinine definition, we have two bullet points, that is, an increase in serum creatinine more than or equal to zero point 0.3 milligrams per deciliter within 48 hours. This reflects an absolute rise in creatinine. Then the next bullet point is that the increase in serum creatinine can be relative. So for you to have a relative increase in serum creatinine, you must know what the patient's baseline serum creatinine is. So whenever you have a patient with one creatinine value, it's impossible to say whether this is an acute kidney injury or whether this is a chronic kidney disease. So it's good if you can have a baseline, but the problem is most patients will be presented to you with renal impairment for the first time, and you will not be, patients may not have previous hospital admissions or previous hospital records or previous measurements of serum creatinine. So based on that fact, sometimes not knowing the baseline creatinine may be a problem when we are stratifying patients as having acute kidney injury based on this bullet point. So if you know a baseline already, increase in the serum creatinine more than 1.5 times the baseline is called as acute kidney injury, and it is also, it has a time duration. It is known to have perceived to have occurred within the prior 7 days. Right. Then we have so we have two parameters based on creatinine, an absolute rise in creatinine or a relative rise in creatinine, and then we have a parameter based on the urine output. So here here we try to define the term oliguria. So oliguria, the definition of oliguria is production of a volume of urine that is insufficient to secrete the total daily solute load. So, the kidney is a very important concentrating organ of producing concentrated urine. Even if you drink liters and liters of fluid, you are able to produce enough amounts of urine to maintain the serum sodium and the serum osmolality in the normal levels if you are having a normal kidney. But the daily solute load of patients from patient to patient as well as within the patient will differ based on how much salt or sodium that the patient is taking, how much protein the patient is taking, and what is the catabolic state the patient is in. So this exact definition of what oliguria is may be controversial. So that is why some would take oliguria as urine volume less than 0.3 milliliters per kilogram per hour for 6 hours. But for the purpose of this talk, we'll be taking oliguria as urine volume less than 0.5 milliliters per kilogram per hour for 6 hours. So does this mean that all patients with AKI will have reduced urine volume? Yes, majority of patients with acute kidney injury will have a reduced urine volume. So these patients are the patients that they understand they are known as having oliguria. Some patients may have no urine at all, and these patients are termed as having anuria. So if you take it for a 24-hour urine volume, then anuria would be defined as somewhere in between 50 to 100 milliliters of urine per day. So anuria means that the patient is having a severe AKI, and even milder AKIs can progress and become anuric. So anuria also is a severe form of oliguria, but some patients may have anuria from the onset of the disease. So we'll be talking about what sort of patients they are when we are discussing the specific causes of acute kidney injury. Then can patients with AKI have a normal urine volume? Yes, a minority of patients with AKI can have non-oliguric acute kidney injury. So we have anuric acute kidney injury, we have oliguric acute kidney injury, and we have non-oliguric acute kidney injury. So when we compare all these three, it has been found out that patients with non-oliguric acute kidney injury, that means those who have a preserved urine volume not falling into the oliguria definition, when they are having acute kidney injury, they tend to have a better prognosis than patients with oliguric acute kidney injury. And you had also note that some patients with oliguric acute kidney injury can get converted into non-oliguric acute kidney injury either spontaneously or with the use of uh, urine volume increasing agents such as diuretics. So if this happens, that means that the kidney is probably recovering. So if your oliguria gets converted to non-oliguria, that means that the kidney is recovering. So improvement of the urine output means that the kidney is recovering. That is why. And some patients can be non-oliguric from the beginning. So based on all these, we have a staging categories of AKI. So various staging categories have been used. Earlier what we used to have was the staging category called the rifle criteria. R for risk, I for injury, F for failure, L for loss, and E for end stage. And we also have a criteria called the AKIM criteria. But based on all these criteria, what the criteria now that we use is known as the KDIGO criteria, the kidney disease impacting global outcome criteria. This is the criteria that we use for both AKI and for CKD. So in the KDIGO criteria, we have 3 stages of AKI, and each stage we have a cutoff serum creatinine as well as a cutoff urine output. So the definition of AKI, with the definition of AKI, all patients will automatically fall into stage 1 AKI, because they will, in stage 1 AKI, they will have 1.5 to 1.9 times the baseline relative increase in creatinine, or more than zero point 0.3 milligrams per deciliter increase in creatinine, which was what we used as the definition of AKI. And they should have less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. So here we have a time cutoff again. So if the oliguria persists beyond 12 hours, then immediately the patient falls into the stage 2 category. As well as if the serum creatinine rise goes beyond 2 times the baseline, patient immediately falls onto the second category, or the stage 2 AKI. And patients with stage 3 AKI, as you can see here, if you have no urine at all for 12 hours, or if you have very low urine output, that is less than 0.3 ml per kg per hour for more than 24 hours, that is 1 day, then you fall onto the stage 3 AKI. Stage 3 AKI also has some serum creatinine criteria. If the creatinine goes above 4, if the creatinine goes 3 times above the baseline, or if you need to initiate renal replacement therapy in patients with AKI, then patients will fall on to stage 3 AKI. So you see, there are different criteria for each stage, but whenever we classify patients with AKI, if we if they have one of the features matching the highest stage, we would classify them as that stage. So whatever the feature that is worst, we would classify the patient as having been in that stage. So it's quite evident that higher the stage, more severe the AKI, and higher the stage, more bad the prognosis. What are the limitations of this staging criteria, right? So we have a urine output criteria. So whether the urine output truly reflects the state of the kidney is one problem. This has not been perfectly validated, as well as the definition does not account for the multiple etiologies of AKI that we are discussing next. And also, based on the baseline will be a problematic, and sometimes the baseline will be fluctuating if the patients are already on renal replacement therapy for other reasons. Right. So what are the types of AKI that we are dealing with? So we have the kidney. You can have an insult in the kidney. You can have an insult before the kidney. So before the kidney meaning insult would be in the blood flow to the kidney, as well as you can have an insult after the kidney. So our kidney drains, produces urine and drains into the ureter and goes into the bladder and all that. So that is the collecting system and the urine outflow tract. So you have pre-renal causes, you have renal causes, and you have post-renal causes. So out of the majority of patients with AKI, most patients will have either a pre-renal or a renal cause. And based on resource settings, whether it's pre-renal or renal would differ. But most commonly in resource poor settings like Sri Lanka, it would be pre-renal causes that are the predominant causes of AKI. So renal causes can be subdivided into acute tubular necrosis, interstitial causes, glomerular causes, and vascular causes, which we'll be discussing in detail next. So again, what I was describing, pre-renal causes tend to reflect the blood flow. So it is due to altered effective circulating volume and renal hypoperfusion. Renal causes could be in the glomeruli, it could be in the interstitium, it could be in the renal vessels. And the post-renal is a problem in the urine outflow tract. Right. So what are the pre-renal causes of AKI? So pre-renal causes could be due to absolute or relative hypovolemia, leading to reduced renal perfusion. So reduced renal perfusion can occur as a result of a systemic process that is if you are having a low circulating volume, again, but your blood supply to the kidney will be reduced. But sometimes you will have a high circulating volume, but the effective circulating volume would be reduced. This happens when you are having edematous conditions like heart failure and cirrhosis. And then there could be problems that everything is normal, but there are some things that are affecting with the renal vessels specifically. So all these three can lead to pre-renal causes of AKI. So true effective arterial volume depletion can happen when you are having losses. So how do you have losses? You can have dehydration, you can have reduced intake, you can have losses to your gut. That is, if you persistently vomit or if you have diarrhea, and then you can have renal losses. Renal losses would be due to diuretics. So excess use of diuretics and not enough fluid supplementation can lead to a pre-renal AKI. And hyperglycemia, as you know, as the glucose concentration increases, glucose absorption has a tubular maximum threshold, and when glucose is present in the renal tubules, it will draw sodium in and will have a polyuria, that is called an osmotic diuresis. And if the patients do not drink in correspondence to the polyuria, then they will have an acute kidney injury. Then again, burns. With burns, you tend to lose a lot of water and salts through your skin and exposed areas, high degrees of sweating and specifically hemorrhage. And when you have third space losses, like when you have severe infections like pancreatitis or peritonitis, then you would have third space losses. Here, septic shock, you will have systemic vasodilatation, but because of the interfering cytokines and the other problems, you will have a significant hypovolemia. In cardiac failure and cirrhosis, you will have myocardial dysfunction as well as you will have splanchnic venous pooling, which will lead to reduced renal perfusion. Shock, obviously, you will have low blood pressure, and because of the low blood pressure, the kidney blood supply will be reduced. So, what happens in all this is that when you have low effecting circulatory volume, this will be detected by the renal by the carotid and the arterial baroreceptors, and when these things are stimulated, they will activate the renin angiotensin aldosterone pathway. So the renin angiotensin aldosterone pathway will try to preserve or increase the sodium absorption from the kidneys as well as cause vasoconstriction. And this vasoconstriction would be specifically in the renal, splanchnic, and the circulation in the skin, trying to preserve the blood supply to the important organs like the brain and the heart. So we were talking about all this glomerular hemodynamics, and even when you don't have this hypovolemia and you can have renal insult, it's sort of a high pre-renal insult when you are on certain drugs. The most common notorious drugs would be here the NSAIDs and drugs interfering with the angiotensin aldosterone pathway. So when talking about NSAIDs, you know that the renal perfusion is dependent on renal prostaglandin production, that is responsible for the renal vessel dilatation. So NSAIDs, when used in excessive amounts, as well as when there is some subtle kidney insult that is ongoing, when you take NSAIDs concurrently with that, what happens is that this renal prostaglandin production will be reduced. So when the renal prostaglandin production is reduced, what the renal prostaglandins normally do would be, they would increase the size of the afferent arteriole to the kidney, maintaining the renal blood flow. So when this renal prostaglandin production is shut off, this afferent arteriole vasodilatation is reduced, thus reducing the renal blood flow. Then what happens, this can also take place when you are taking drugs such as cyclosporine, which are calcium inhibitors. So what happens when you take angiotensin receptor blockers like losartan or ACE inhibitors like enalapril? What they do is that the angiotensin 2 is important in producing both afferent and efferent arteriolar constriction in the glomerulus, but it causes more constriction in the efferent arteriole. So when there is significant constriction in the efferent arteriole, the glomerular pressure increases, and that will preserve the renal perfusion. So when we decrease the angiotensin action by the use of angiotensin receptor blockers or ACE inhibitors, what happens is that this efferent arteriolar constriction gets reduced. So that means the glomerular pressure will decrease and the glomerular filtration rate will fall. So on all these causes of AKI, either due to effective arterial volume depletion, that is either true or absolute, or when there are drugs that are all affecting the glomerular hemodynamics, what we'll have is that the glomerular filtration will be reduced. But this glomerular filtration reduction will result in increase of the creatinine, but you have to know that the everything in the kidney will be normal. So if you increase the renal blood flow by correcting all these factors, since there is no kidney insult, that means the glomeruli are normal, the tubules are normal. So if we supply or reduce this insult and supply the effective arterial volume to the kidney should be okay and should recover without any damage. So what happens after that? Right. So when there is persistent blood flow reduction to the kidney, little by little, you will get sustained underperfusion of the renal tubules. So sustained underperfusion of the renal tubules will lead to tubular necrosis. So persistent prerenal AKI can go into renal AKI if the cause is not corrected immediately. So there are certain cases of ATN from the onset, but pre-renal causes can go into renal AKI by acute tubular necrosis. So sustained underperfusion will cause acute tubular necrosis, and these tubules will get blocked, or these tubules will get deposited in the tubular lumen that scars and cause problems in the kidney. So this can happen as a result of a pre-renal AKI going into renal AKI, or there are some instances where ATN occurs itself. These are the instances where there is pigment damage. So when you have heme pigments like hemoglobin or myoglobin, either due to rhabdomyolysis or due to severe intravascular hemolysis, then you can have this renal tubular toxicity causing renal tubular death. And right, so we'll just quickly go through, so you may be confused on what I was talking about. So this is what I was talking about earlier. Let's quickly recap this. AKI definition based on the absolute increase in creatinine of 0.3 within 48 hours, or a relative increase in creatinine more than 1.5 times the baseline, or the concept of oliguria that I was talking about, that is 0.5 milliliters per kilogram per hour for 6 hours. Then we had the rifle and the Akin criteria that I was describing, and here is the KDIGO criteria that we are here. We have the stage 1 AKI, that is 1.5 times the baseline with reduction in urine output for between 6 to 12 hours. Then we have the stage 2 criteria with more than 2 times the baseline, or less than 0.5 milliliters per kilogram per hour for more than 12 hours. And here we have stage 3, more than 3 times the baseline, or increase in creatinine to more than 4, or when you have anuria for more than 12 hours. So whatever the higher the feature that you have, then you try to classify the patient as being in that category. Again, this will have limitations. So these are the types of AKI: pre-renal, renal, and post-renal. And renal can be subdivided again into ATN, interstitial, glomerular, and vascular. So again, in a diagram, pre-renal, renal, and post-renal of the collecting ducts. Right. Then we have pre-renal causes. This is what I was talking about: hypovolemia. with dehydration, gut losses, shock, and then right, and then third space losses. Then there could be features like cardiac failure or cirrhosis where there is a hypervolemia, but there is reduced perfusion to the kidneys. Then I was talking about drugs interfering with glomerular hemodynamics, NSAIDs, cyclosporine, and angiotensin 2 receptor blockers. Here we are now regarding ATN, right? So we are caught up to now. So as I was talking about, uh, pre-renal AKI, when more profound, can go into renal AKI that causes ATN, and there are some instances where ATN itself can occur from the outset. One instance like that is a nephrotoxin like heme pigments, where there either hemoglobinemia or myoglobinemia leading to acute tubular necrosis. Then we have other drugs which can cause ATN. So drugs would include drugs like vancomycin, then drugs like gentamicin, which are aminoglycoside antibiotics. Then when you are having patients on chemotherapy, especially these platinum-based chemotherapies that you learn in your gyn and obs, they can cause direct renal injury causing acute tubular necrosis. And when you have hemorrhage, burns, and excessive diuretic use, they can predispose to ATN from the outset or pre-renal AKI going into ATN. There are other causes of renal causes of AKI, but they are quite rare, and these would include vascular causes, and most of these vascular causes would be in the small vessels in the kidneys. So they would be in the form of small vessel vasculitis or pathologies like hemolytic uremic syndrome or TTP or malignant hypertension. Small vessel vasculitis would involve things like ANCA vasculitis. Then you would have large vessel involvement. That would mean that your renal arteries are compromised, and it would mean something like bilateral renal artery stenosis or unilateral renal artery stenosis with a single functioning kidney, or something like bilateral renal arterial obstruction by maybe a dissecting aortic aneurysm. Right. So out of the renal causes, we have acute tubular necrosis, then we have vascular causes, then we have glomerular causes. So glomerular causes are broadly classified as glomerular nephritis. So if you already know, you may know that glomerular nephritis can present as a nephritic syndrome or a nephrotic syndrome. So usually when uh, AKI occurs in patients with glomerular causes, they usually tend to have a nephritic picture. That is, they would have not that much of edema, but they would have intravascular volume overload with hypertension and reduced urine output. And classically, in patients with glomerular nephritis, they can present with microscopic or macroscopic hematuria, and they can have features of glomerular damage, which are known as red blood cell casts or dysmorphic red cells. So when the red cells pass through the damaged glomeruli, they can break and they can manifest as dysmorphic red cells. So important causes of acute kidney injury that are nephritic in picture would include post-infectious glomerulonephritis, which is very common in children, lupus nephritis, which occurs in SLE, and IgA nephropathy. So all these are causes of CKD also, but they can cause AKI. In contrast, nephrotic syndrome, having an AKI is rare, but you can have AKI in nephrotic syndrome also. So we have the vascular causes, we have the glomerular causes, we have the tubular causes, and then we have the interstitial causes. So when you have inflammation in the interstitium, specifically this is called as interstitial nephritis, and this is mostly drug related. You can have problems in the kidney function. So there are causes of acute interstitial nephritis as there are causes of chronic interstitial nephritis. So you know that kidney disease is very prevalent in Sri Lanka, and it is sometimes called as CKDU. And however, CKDU has been identified as a chronic interstitial nephritis. But that is out of the scope of this discussion. We are focusing on acute interstitial nephritis. Right. So what are the post-renal causes? So any cause that is causing obstruction can lead to post-renal causes. It could be an obstruction of the ureter, which happens commonly due to stones, or it could be tumors. Tumors could be the ureter or outside the ureter, like ovarian cancers or retroperitoneal cancers. And it could be due to ureteral strictures, which could happen incidentally or it could happen iatrogenically. Then you have causes of bladder outlet obstruction, and this is very common in elderly males due to benign prostatic hyperplasia. So when BPH occurs, it usually causes a distal obstruction and patient will have these significant obstructive lower urinary tract symptoms. Then you can have bladder cancers that are causing bladder outlet obstruction, as well as if there are huge bladder stones or urethral strictures, again you can have a bladder outlet obstruction. Right. So moving on to the final part. So how do you manage patients with AKI? So there are no uh, interventions that will reverse the AKI. So management of AKI is primarily supportive. So when we are managing patients with AKI, first we have to identify which patients are in priority. So whenever patients have an AKI, they can have signs and symptoms of acute kidney dysfunction. So what are these signs and symptoms? So when the kidney is damaged, you can have accumulation of these toxic metabolites, that is urea and the toxic nitrogenous substances. So when these occur, you can get a whole variety of symptoms, right? So you can get anorexia, you can get nauseous, you can have vomiting, then you can have metallic taste in the mouth, you can have itching, you can have something like a uremic frost where you get frosting of the skin. So you can have signs and symptoms like that. And based on the complications of all these, which we'll be discussing, you can have other symptoms. And also, depending on the cause of the AKI, they may have significant urinary symptoms. So you can ask for a previous history of obstructive bloods, what the drugs the patients are taking, as well as whether the patient has any significant proteinuria, hematuria, or whether there's any past history of stones. So when you have patients with AKI, you have to identify immediately which patients are in an emergency. So we'll be talking about that later. So after you identify which patients are in an emergency, then you can think about how to manage patients with AKI. So after dealing with patients with an emergency, you have to find out what the cause for the AKI is. So finding out the cause for the AKI, you have to take a thorough history and physical examination. So they would be behind all the focusing on all the causes of AKI that I listed earlier. Then we have to discontinue all nephrotoxic agents when possible, because AKI takes some time to resolve, and if there are ongoing renal insults, the period of recovery from AKI will get prolonged. So you have to discontinue nephrotoxic agents as much as possible and try to reduce the renal hypoperfusion. So you have to check the volume status of the patient and ensure the perfusion pressure is adequate. So for doing that, you can go by the urine output, you can go by the pulse rate. So if you're having tachycardia, that would mean that the patient is volume depleted. Then you can see for signs of fluid overload, like the jugular venous pressure elevation, and then whether you have bibasal crepitation suggestive of pulmonary edema, and you can have effusions also if there is significant albuminemia. Then you can also go by skin turgor and capillary refilling time. Then you can consider functional hemodynamical monitoring, which would be with regular monitoring of pulse rate, blood pressure. And then monitoring of the serum creatinine and urine output is important because serial measurements would be necessary to see whether the AKI is bursting or not. Then you should try to avoid hyperglycemia as much as possible. And then you should consider whether there are any alternatives if you need to undergo radio contrast procedures. So after doing all this, uh, there are certain investigations that will be necessary to determine the cause of the AKI. So serum electrolyte is again very important because there are electrolyte disturbances in patients with AKI. You can have hyponatremia, you can have hypernatremia. Potassium-wise, most often you would encounter a hyperkalemia with increased potassium levels, and then there will be so calcium and phosphate abnormalities like low calcium and high phosphate. But hypercalcemia itself can be a cause for AKI, so you have to be careful with interpreting those investigation findings. So urine wise, we would be doing a urine analysis in the form of a UFR, where we'll be selectively looking for certain elements in the UFR to see whether their patient is having any evidence of glomerulonephritis or acute tubular injury. So if you're having glomerulonephritis, as I mentioned earlier, you can have features like red cells or red cell CAS or dysmorphic RBC, which we'll have to ask separately with a separate investigation. Then you'll be looking at whether there's any significant proteinuria. Presence of high WBC would suggest that there is infection in the kidney or in the urine in the form of either cystitis or pyelonephritis. And then we will be going for certain other investigations to determine the cause of pre-renal versus renal AKI, which we'll be discussing in the questions that follow. So when all these factors are done, and you would also go to see the kidneys ultrasonically. So imaging is a modality that we use in most patients with AKI to see whether we are actually dealing with an AKI or whether you are dealing with a patient with chronic kidney disease. Imaging is also important to see whether you are having a significant obstruction in the kidney. So it could be an obstruction in the kidneys leading to hydronephrosis, it could be obstruction down leading to hydroureter or leading to a chronically enlarged bladder, or like whether the patient is having features of prostate enlargement. So the ultrasound would serve two purposes: to exclude obstruction as to see what the sizes of the kidneys are. So in AKI, usually the kidney size will be preserved, or sometimes the kidney size could be enlarged if there is collection in the kidney with either urine with hydronephrosis or pus in the kidney like pyonephrosis. And patients with CKD tend to have shrunken kidneys. And the echogenicity of the kidneys would be increased in both AKI and CKD. And you know, in the kidney, there are two parts, the cortex and the medulla. So the demarcation between the cortex and the medulla would be diminished in patients with CKD, and it will be preserved in patients with AKI. So, but you have to bear in mind that there are conditions of CKD where the kidney size will not be shrunken. So, so there are caveats in all of this, right? So, discontinuing the nephrotoxic medications is an important here, as well as you have to change the drug doses, because most of the drugs, some of the drugs that we use here will be excreted by the kidneys. So when the kidney function falls, the concentration of these drugs can increase. So that will have problems with either the physiological effect of the drug as well as adverse effects of the drug. So some drugs that we would like to exclude or reduce to change the doses in patients with AKI would be metformin. So metformin in the presence of AKI can predispose to lactic acidosis which can further compromise the morbidity of patients with AKI. So metformin, uh, antibiotics like piperacillin, tazobactam, vancomycin will have to change the doses or substitute other drugs if we are using in patients with AKI. Right. And okay, so when we get a patient with AKI, after doing all that, you have to after assessing the patient's fluid status, you can see whether the patient is fluid responsive. So if the patient is having clearly low blood pressure, or if the patient is having tachycardia with low urine output, with increased capillary filling time, and maybe even low blood pressure, you obviously need fluids. So what fluids to give in AKI? So giving fluids in AKI is a challenge because the kidney is not working properly. Too less fluids can worsen the AKI, as well as too much fluids can cause other problems. So you have to balance out the fluids when you are dealing with patients with AKI. So if you are definitely hypovolemic, you can try infusing isotonic crystalloid. So the isotonic crystalloid that we commonly use here is normal saline. So if you have a definite volume depletion, you can give about 1 to 2 liters of normal saline to see whether the patient is fluid responsive. Fluid responsive meaning the blood pressure will pick up and the pulse rate will decrease and the capillary refilling time will decrease, and the urine output will gradually start to improve. But careful monitoring is required because the kidney is not working. Even with that amount of fluid, some patients can go into fluid overload. So fluid overload again would be suggestive as with a high blood pressure, with uh, uh, increased pulse pressure, and development of bibasal crepitations and elevated JVP. And if the blood pressure is very low, you would obviously need vasopressors to maintain the perfusion. So to maintain renal perfusion, you would at least need a mean arterial pressure of 65 to 70 millimeters of mercury. So what to do if the patient is not classically volume depleted? Then you can closely give fluids at around 50 to 60 or maybe even 1 ml per kg per hour to see whether the patient is fluid responsive. Here, bolus doses are not necessary. So you would tend to go for an input of around 1 to 1.5 liters per day if the patient is having a, a, a significantly measurable urine output. But if the patient is having anuria or having very low urine output, again, giving this much or even this much of fluid can be problematic. So we tend to go for, if you are calculating the 24-hour input requirement, we tend to go for the previous day's 24-hour urine output plus 500 ml to balance out the insensible losses when you are calculating the input for the next day. Or if you are calculating the input hourly, you would go for the previous hour's urine output plus around 40 cc to balance out the insensible losses when you're deciding on the input for the next hour. And giving fluids is not at all advisable if the patient is having anuria. In such cases, if the patient is in significant volume overload, you can try giving diuretics. But if the patient is oliguric and has definite hypoperfusion, diuretics are not recommended. So diuretics can be used as a short-term goal for controlling the volume overload. The use of diuretics has not been shown to improve the outcome of acute kidney injury. So maintaining the fluid status, so you see it's a very complex process of balancing the fluids as well as balancing the diuretics and maintaining the blood pressure. So then you have to find out the cause and treat the cause for AKI. Some of these causes may be reversible. So you should discontinue the nephrotoxin. If there is obstruction, you relieve the obstruction. There is glomerulonephritis, you treat the glomerulonephritis, and if there is sepsis, you try to control the sepsis. So you have to be very careful when you are dealing with AKI, because AKI can easily go into complications. So complications would be hyperkalemia, metabolic acidosis, hyponatremia or hypernatremia. So if you're having hypernatremia, giving normal saline, no isotonic saline would be problematic. We'll have to think about other crystalloid solutions like rigorous lactate or half normal saline. And if you're having pulmonary edema, again, you will have to think of diuretics to improve this patient's hypoxia. Right. So, what are the indications for renal replacement therapy? So, these are the emergency criteria that you'll be looking at when managing patients with AKI. So, emergently, they would need renal replacement therapy if all these things are of if all or one at least one of these things are fulfilled. So you see on the first three, you would have uh, clauses saying that resistant to medical therapy, resistant to medical therapy, or resistant to medical therapy. So what does that mean? That means that renal replacement therapy is not the treatment for AKI. That is, dialyzing the patient is not the treatment for AKI. Dialysis is only a supportive measure. So what do you do if you have pulmonary edema? You can try giving the patient furosemide. So some patients will already be on furosemide. So you'll have to at least double the dose to give as the initial dose. So we would give at least a minimum of IV furosemide about 80 milligrams to see whether their patient is responsive to diuretics. So that should produce at least 100 to 200 ml of urine if the patient is responsive to diuretics. And but if the patient is having severe hypoxemia, the patient is not responsive to diuretic, that is, the patient is not producing that amount of urine, or if the patient is completely anuric, then that would mean that the patient's volume overload and pulmonary edema is not responsive to medical therapy. Then only that you would go for uh, renal replacement therapy. If the patient has some improvement with IV diuretics, then you can try increasing the dose of IV diuretics or repeating the doses to reduce the volume congestion in the patient. Then you will be talking about hyperkalemia. Then also hyperkalemia, you have to see whether the patient is in a hyperkalemic emergency. So what is a hyperkalemic emergency? Any potassium level that is more than 6.5 millimoles per liter is a hyperkalemic emergency. Also, there could be hyperkalemia that is causing end organ dysfunction. So hyperkalemia that is causing end organ dysfunction is another hyperkalemic emergency. So what are the organs that the high potassium level can affect? The organs that high potassium level can affect are the heart and the muscles. So if you have very significant hyperkalemia, sometimes you will get muscle weakness and muscle paralysis. And also when you have very significant hyperkalemia, you will get cardiac contraction abnormalities. So if you take the ECG, it's like the P, QRS, and T. So you have to remember the changes of hypokalemia. You take the PQRST, normal ECG, and you pull from each side. First, you pull from this side. That would mean your T would go up. So tall tender T waves are the first ECG manifestation of hyperkalemia. Then you pull from this side. That is your PQ interval, or uh, the size and the P wave, and the QRS complex would decrease, and then finally it would go like a QRS sine wave. So the PR interval will increase, 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 then the P wave will get flattened, and finally the QRS will be like a sine wave, and finally the whole ECG will be flat and the patient will be dead. So what to do? So when you're having significant hyperkalemia because of the cardiac conduction problems, whenever you have ECG changes of hyperkalemia, you have to be looking at tall tended T waves, increased uh, QRS duration, decrease in the shape of the P wave, as well as the QT interval, and the QR interval should be prolonged if you are having significant hyperkalemia. So the PR interval is also important here. So what do you do? When you have ECG changes of hyperkalemia, you would give something to stabilize the cardiac muscle. So stabilization of cardiac muscle is achieved by giving calcium gluconate. So it's easy to remember how much calcium gluconate to give. It's 10, 10, 10. That is 10% calcium gluconate, 10 ml over 10 minutes. So that giving that will not reduce the potassium level. It will only stabilize the cardiac muscle. So to prevent it from going into malignant arrhythmias. So you to reduce the potassium level, you must give treatment. So what is the treatment that you give? You give a treatment called insulin dextrose. That is, you give 50 milliliters of 50% dextrose combined with 10 units of soluble insulin. So the insulin will help push the extracellular potassium inside the cell, thus reducing the hyperkalemia. Also, when you are giving diuretics, furosemide will help to reduce the potassium. And when you are giving acidosis correction, that will also help to reduce the potassium. And you can try things like salbutamol nebulization that will also push the potassium inside the cells and reduce the hyperkalemia. So if the patient is having very high potassium level, again, that could be an indication for dialysis. Then if you have uh, high potassium level with either ECG changes or muscle weakness, then it could be an indication for dialysis. Then if you have high potassium that is more than 6 or 5.5 with ongoing tissue damage like rhabdomyolysis or having renal failure, then again that would mean that the patient is in a hyperkalemic emergency and would need treatment. So if the patient does not respond to any of these, that is the insulin dextrose, the calcium gluconate and salbutamol, then you have no option rather than to dialyze the patient. Then you have acidosis. So acidosis can be seen in both AKI and CKD. And when you have acidosis, anything below 7 point pH of 7.35 is called acidosis. But here we try to look at severe acidosis, that is pH less than 7.1. So when you have acidosis, you try to go for the bicarbonate level also. If the bicarbonate is very low, that is less than 15, you try to give the patient IV sodium bicarbonate. It is usually given as a bolus dose. You can give IV sodium bicarbonate 100 to 150 milliliters. And if the patient is having less severe AKI with a bicarbonate of more than 18 or if the patient is having a pH of more than 7.1, that is hovering around 7.35, you can try giving the patient oral sodium bicarbonate. Again, this will correction of the acidosis will help correct the hyperkalemia as well as correction of the volume overload with furosemide will also help reduce the acidosis. So all of these first three indications you can try first with medical therapy. If persistent only, you need to go for renal replacement therapy. And what about other organ manifestations of uremia? If you have uremic encephalopathy or uremic pericarditis, that is a definite indication for dialysis because that if you are not dialyzed the patient, that could have significant morbidity and mortality impacts on the patient. So how do you identify patients with uremic encephalopathy? They could be drowsy, they could be having fits, but you in the physical examination you can look at flappy tremors, which are can be seen in hepatic encephalopathy also, but they can be seen in uremic encephalopathy. And uremic pericarditis, you may not be able to definitely diagnose it, but if you hear pericardial rub, in your examination, or if the patient complains of chest pain with non-dynamic ECG changes, you have to suspect uremic pericarditis, and then there would be definite indications for renal replacement therapy. So if the patient does not have these indications at the moment, trying renal replacement therapy early or late does not impact the outcome of patients with acute kidney injury. So as I said earlier also, renal replacement therapy is not the treatment option for AKI. It is only a supportive measure to help support the kidney. So AKI, although it is very acute and short lasting, the recovery of AKI may take weeks and weeks. So that is why you have to wait until 3 months before you call a patient as having CKD. So the recovery of AKI may depend on certain factors that could depend on the initial insult, the duration of the insult, whether there are ongoing renal insults like hypoperfusion or nephrotoxic medications. Some patients may recover, some patients may never recover from the AKI and may need persistent dialysis and go into chronic kidney disease. But some patients will recover but not achieve their baseline glomerular filtration rate. So that is all as theory wise what I wanted to highlight you. So let's see whether we grasp that with a few questions. Right. So I'll give you about 2 minutes and then we'll discuss the answers for this. Right. So the first question is regarding pre-renal AKI. It is primarily caused by reduced renal blood flow. That is true. Pre-renal AKI results from factors that reduce blood flow to the kidneys, leading to reduced glomerular filtration. Common causes include heart failure, dehydration, and sepsis. Yes, that is true. These conditions reduce the effective circulating volume, leading to reduced renal perfusion. The fractional excretion of sodium is typically low in pre-renal AKI. Right. So here's what I wanted to discuss in this. So when we are considering patients with pre-renal versus renal AKI, mainly the acute tubular necrosis patients, there are certain factors that help us determine. So there's factors some factors may be very helpful, some factors may be not that helpful. So one such factor is this fractional excretion of sodium. Other factors would be things like urine osmolality, urine sodium. So in urine sodium, in pre-renal AKI, what will happen to the urine sodium is that the kidney will try to preserve the sodium. So the urine sodium will be low in patients with pre-renal AKI. Whereas the tubules will not have that much of concentrating effect. So when you are having acute tubular necrosis, the urine sodium will be high. So urine sodium less than 20 is seen in patients with pre-renal AKI. So what about the urine osmolality? So again, patients with pre-renal AKI will have highly concentrated urine. So they will have a high urine osmolality. Again, patients with acute tubular necrosis will have a, a low concentrated urine. So they will have a very dilute urine. So they will have a low urine osmolality. Both of these, the urine volume has a significant play in that. So because of that, it is not absolute to pre-renal versus acute tubular necrosis because there can be significant overlap based on the urine volume. Hence, the best indicator to differentiate all this is the fractional excretion of sodium. For the measurement, it does not require the urine volume. So the fractional excretion of sodium will be very low in patients with pre-renal AKI, and the fractional excretion of sodium will be high in patients with AKI. So being low means in pre-renal it will be less than 1%, and in acute tubular necrosis it will be more than 2%. So this is true. A urine sediment showing muddy brown cast is characteristic? No. Muddy brown casts are a feature of acute tubular necrosis in uh, pre-renal AKI. You can get some casts. These are known as highline casts, which could be there in normal patients also, or it could be there in pre-renal AKI. But muddy brown cast because of the necrosed tubular cells which are slumped off in the tubules and excreted in the urine are a characteristic. Muddy brown granular casts are a characteristic feature of acute tubular necrosis. So this is false. Rapid volume expansion is the mainstay of treatment. True. Restoring renal blood flow is the primary goal and volume expansion is often necessary. Right. Let's go to the next question. Right. You can have about 1 minute to answer this. Right. So let's discuss this question. So regarding intrinsic AKI, ATN is the most common cause of intrinsic AKI. Yes, it is the most common cause. It results from damage to the renal tubules, often due to ischemia or nephrotoxins. Aminoglycoside antibiotics are a common cause of ATN. True, aminoglycoside antibiotics are nephrotoxic. Other antibiotics include vancomycin and things like piperacillin tazobactam. And they are nephrotoxic and it can cause tubular damage. Acute interstitial nephritis is often associated with an allergic reaction to medications. Yes, that is true. AIN is an inflammatory response in the renal interstitium, often triggered by drugs. Renal biopsy is rarely helpful in diagnosing intrinsic AKI. Yes. So, invasive procedures like renal biopsy should only be performed if the history, physical examination, ultrasound imaging, and the other laboratory features do not arrive at a specific cause for the AKI. So renal biopsy can be crucial in such situations in diagnosing intrinsic AKI causes such as AIN or glomerular nephritis, because glomerular nephritis sometimes can rapidly progress and may require immediate treatment with immunosuppressive therapy. In that cases, expediting a renal biopsy will be important. Rhabdomyolysis-induced ATN is treated with aggressive hydration and urine alkalinization. True, when you have rhabdomyolysis or when you have significant heme pigment nephropathy, you need high volumes of fluid. So you will go for fluid volumes exceeding 150 to 200 milliliters per hour to prevent the myoglobin precipitation in the tubules, and urine alkalinization can be done. Okay, so regarding post-renal AKI, it is caused by obstruction of urine outflow. True, obstruction anywhere along the urine tract can lead to post-renal AKI. Common causes include BPH and kidney stones. True. Bilateral urethral obstruction is necessary to cause post-renal AKI. That is false. If you have a single functioning kidney, obstruction there can cause post-renal AKI. Ultrasound is the initial imaging modality choice for patients with post-renal AKI. True, ultrasound is a non-invasive and can readily detect hydronephrosis when performed with expertise. Relief of obstruction always leads to complete recovery of renal function. No, if the degree of recovery depends on the duration and severity of the obstruction, and sometimes if it's more severe and if it's for prolonged durations, the recovery may be questionable. KDIGO guidelines define AKI based solely on changes of serum creatinine. No, it uses both serum creatinine and urine output. Stage 1 AKI is defined as an increase in serum creatinine of more than zero point 0.3 within 48 hours. Yes, true. Stage 3 is defined by a urine output of less than 0.3 ml per kg per hour for more than 24 hours. True. Also, you can have anuria for more than 12 hours. And then KDIGO guidelines recommend using both absolute and relative changes in creatinine. True, this provides a more comprehensive assessment of AKI, although there are pitfalls in it. Staging of AKI helps in predicting prognosis and guiding management. True, higher the stage, worse the prognosis, and more intensive treatment is necessary for patients with stage 3 AKI. That is true. Last question in the true false. Hyperkalemia is a common and potentially life-threatening complication of AKI. True, can cause life-threatening muscle weakness as well as life-threatening cardiac conduction abnormalities because of impaired potassium excretion. Metabolic acidosis is treated with sodium bicarbonate only in severe cases. True, overcorrection of acidosis can lead to various other complications in AKI. So bicarbonate is used selectively in patients. Diuretics are the first line treatment for all patients with oliguric acute kidney injury. Wrong. It can be tried in patients with non-oliguric acute kidney injury or with patients having when patients are in clear fluid overload. And of course, in oliguric acute kidney injury, diuretics are not always effective and can be harmful. Renal replacement therapy is indicated for refractory hyperkalemia, metabolic acidosis, and volume overload. True, these are the common indications. Nutritional support is an important part of AKI management. True, adequate nutrition is essential for the recovery, but you have to be careful about the salt content of these patients because they worsen the hypertension as well as the phosphate content. Hyperphosphatemia is a common problem uh, the AKI as well as the protein content. So it should not be a low protein or a high protein diet. It should be a normal protein diet in patients with AKI. Then I have some SBS for you. Can take about 1.5 minutes to think about the answer for this. We have some engagement in the chat. Yes. So here we have a 70-year-old male with a history of BPH who presents with anuria for 24 hours. His serum creatinine is 4.5, baseline is 1. So he has anuria as well as the creatinine is more than 3 times the baseline. And that means the patient is in stage 3 AKI, that is severe AKI. And the ultrasound reveals bilateral hydronephrosis, which is a little uncommon for patients with benign prostatic hyperplasia. But even with BPH, you can have the bladder having gone into chronic retention, with the bladder becoming hypertrophic. Then you can have vesicoureteral reflux as well as ureteral stenosis that can lead to ureteral obstruction and then finally go into hydronephrosis. So, which of the following is the most appropriate initial management? So, there is definite obstruction and the patient is in severe AKI. So, there you need to place immediate placement of bilateral percutaneous nephrostomy tube. So if there was an option like placing a urinary catheter, you can try that before proceeding towards something more invasive like percutaneous nephrostomy tube. But that option was not there, and so you had to go for immediate placement of bilateral PCNs. Right. So there are some answers coming up. So in this patient, we have a 65-year-old male 65-year-old patient with septic shock developing an AKI. They have significant nephrotoxic medications like vancomycin and piperacillin tazobactam. But I'm asking is, which of the following would strongly suggest acute tubular necrosis? So fractional excretion of sodium of less than 1% would suggest that the patient is having pre-renal AKI. In ATN, it would be more than 2%. Urine sediment with red blood cells and protein would suggest that the patient is having glomerular nephritis. Okay. And the next thing is elevated urine osmolality. So high urine osmolality would suggest the patient is having pre-renal cause because low urine osmolality is expected in ATN and low urine sodium. So low urine sodium can be seen in both pre-renal as well as some intrinsic causes. And typically in ATN, you would expect the patient to have high urine sodium. So the correct answer would be muddy brown granular cast. So this is a little bit of a difficult thing because I specifically didn't cover this topic in this section because I wanted to discuss this in the SPA. So a 55-year-old patient with a history of chronic NSAID use. So NSAIDs can predispose to uh, various causes of AKI, both pre-renal and renal. Presents with AKI and a rash. So there's AKI as well as there's a rash. And rashes can be seen in patients with AKI if there are significant vasculitis, there are autoimmune disorders, or in this specific condition. Urine analysis shows hematuria and proteinuria. So hematuria and proteinuria will not always mean that the patient is having glomerulonephritis. Hematuria and proteinuria can occur in interstitial diseases also. Key feature here is that there are eosinophils noted in the urine. So when you have increased urinary eosinophils, that would suggest that this is a allergic reaction. So the answer would be acute interstitial nephritis because of the AKI rash, hematuria, specifically the eosinophiluria, and there's a clear antecedent trigger, that is the NSA use. As most SBAs, there are two answers that go very close by, and you have to select the best one out of that. So here we have a 78-year-old patient with congestive heart failure. So patient is already having fluid overload and the patient is elderly and the patient is having AKI and the serum creatinine has increased from 1.2 to 2.8. That is almost the patient is in stage 2 to stage 3 AKI. So in 48 hours and is oliguria. So which of the following is the next most appropriate step in the management? So administering a large bolus of intravenous fluid is of course out of the question. To give fluids, patient will go into hypoxia. Performing a renal biopsy. So here we have, most probably we have some clear cause for the congestive, clear cause for the AKI because the patient has gone into heart failure exacerbation and probably in cardiorenal syndrome. Increasing the dose of their current ACE inhibitor. ACE inhibitors in AKI can be dangerous, but ACE inhibitors are used in the chronic management of heart failure, but it is not an option at the moment. So the option is deciding whether between you need to start high dose furosemide or whether the patient is in renal replacement therapy. So patients with volume overload may have blunted response to diuretics, and since the patients are already on diuretics, right? So the answer here would be that we should initiate renal replacement therapy because high dose furosemide is unlikely to be effective in this patient. Here you have to be careful when you're trying to guess the answer. A 45-year-old patient with a history of multiple myeloma presents with AKI. So there are multiple reasons for kidney damage in patients with multiple myeloma, but the main reason for kidney damage in patients with multiple myeloma is cast nephropathy or the light chains getting deposited in the renal tubules. So which of the following is the most effective strategy to prevent further renal damage in this patient? So let's go with each of these. So aggressive hydration and urine alkalization looks like a sensible option because that will reduce the effect of the light chains as well as it will prevent their precipitation. Administration of NAC. So NAC is a drug that is usually given to prevent contrast-induced nephropathy, although there is not much proven benefit for it. Doesn't seem like a viable option here. Discontinuation of all nephrotoxic medications, of course, that is necessary, but it's not the most important in this setup. Plasmapheresis, yes, plasmapheresis may be an option because to get rid of all these light chains and to prevent to improve the kidney function, and administration of high dose corticosteroids. So that will help prevent the myeloma, that will help control the myeloma and the production of light chains and further compromising the kidney function. So all A, D, and E seem like viable options, but the correct answer here would be A, because we are asking the most important strategy to prevent further renal damage. So aggressive hydration and urine alkalization is the best way forward because light chains will precipitate and the aggressive hydration and urine alkalization will increase the solubility of these light chains and increase the excretion. So as I mentioned earlier, plasmapheresis and steroids also can be used, but that will help prevent the myeloma or help control the myeloma, but hydration would be the most important initial step. Right. So That is all what I have for you today. And finally, there are some difficult questions, so you can try these things at your leisure. And we'll share the answers, or you can come up with the questions if you need further discussion in the group. Right. So we have 12 questions here. You can try these at your leisure. We can come up with the answers in the group or when we meet next time for another class. Right. Do you have any questions on what we discussed today? Right. So Iranda wants me to brief the KDIGO classification again. Yes, we'll go through that. Right. So AKI would mean that there's an abrupt decrease in kidney function, which would have under these bullet points of absolute increase in serum creatinine, a relative increase in serum creatinine, or oliguria. So the with how much oliguria is different from person to person, and it's different in different definitions. But in the KDIGO, what we term as oliguria is urine output less than 0.5 milliliters per kilogram per hour for 6 hours. So we have had the rifle criteria, we have had the Akin criteria, but the KDIGO criteria is the one that is commonly accepted now. So here we have the 3 stages in the KDIGO criteria. So we need to have oliguria, but if the oliguria is persistent between 6 to 12 hours, patient would fall into AKI stage 1, and patient need to have creatinine more than 1.5 times the baseline. And if it's in between 1.5 times to 1.9 times on the baseline, patient would be in stage 1. Or if the just the 0.3 increase is there, that would mean that the patient is in stage 1. If the oliguria is persisting between more than 12 hours but less than 24 hours, patient would be in stage 2 AKI, and creatinine wise, it would be 2 to 2.9 times the baseline. That means patient would be in stage 3. So because there are creatinine criteria and urine output criteria, whatever the worst criteria the patient fits into, you classify the patient as being in that stage. Stage 3 would mean whether the patient is having anuria for more than 12 hours or having oliguria for more than 24 hours, then the patient is in severe AKI or stage 3 AKI. Creatinine wise, if the creatinine has gone more than 4, that is the absolute level, that would mean that the patient is in stage 3 AKI. Or if you know the baseline, which may be a questionable fact, but if you know the baseline, if it's more than 3 times the baseline, again the patient would be in the stage 3. And if you need to initiate renal replacement therapy for any of the indications that I mentioned earlier, like pulmonary fluid overload, acidosis, hyperkalemia, or uremic encephalopathy or uremic pericarditis, again, patient would be in stage 3. So, your key fact is identify which patients are in the stage 3 because they would need more urgent or maybe even emergency management. Right. Okay. I hope that is enough. A very important topic, as well as it's a very and common problem that we encounter in both as outpatients as inward patients. It is described by absolute increases in creatinine, relative increases of creatinine, or reduction in urine output. We use the KDIGO criteria to categorize the AKI because that is important in prognostication. There are 3 stages of AKI, and the criteria that we use is the KDIGO criteria. AKI wise, we have insults pre-renally, we have insults in the kidney, or we have insults after the kidney. The renal insults can be in the vessels of the kidney, it can be in the glomerulus, it can be in the interstitium, or it can be in the tubules. Post-renal insults could be anywhere in the outflow tract. So pre-renal insults may be due to true volume depletion in these situations, or in with relative volume depletion when the patient is edematous, or due to drugs affecting the glomerular hemodynamics. Renal main cause would be acute tubular necrosis because severe pre-renal AKI can go into acute tubular necrosis, or you can have acute tubular necrosis from the outset, like in these conditions, as well as when the patient is on nephrotoxins. Vascular causes would involve small vessel problems as well as large vessel problems. Glomerular causes would be nephritic and nephrotic. Nephritic feature most commonly, and interstitial causes would be acute interstitial nephritis, commonly caused as an allergic reaction to drugs. Postrenal would be obstructive causes. It should be stones, strictures, or tumors or benign prostatic hyperplasia. Management would be identify patients who would need urgent and emergency management, ensuring the volume status, measuring the creatinine and the urine output regularly, and giving uh, finding out the cause and treating the cause for the AKI, as well as doing ultrasounds and performing the normal laboratory investigations to find out the cause and to exclude obstruction. Changing the drug doses may be important in certain drugs because drugs can be eliminated, excreted renally, and if these drugs accumulate, then there may be problems. For optimal renal perfusion, you may need hydration. If the patient is significantly volume depleted, bolus doses. If it is relatively volume depleted, maintenance fluid. But if the patient is fluid overload, no fluids, but patient would need diuretics. If the blood pressure is low, you would need vasopressors, and you have to identify and treat the cause. Then watching out for the complications, and finally the indications for renal replacement therapy. Pulmonary edema that is resistant to IV furosemide, hyperkalemia with ECG changes, muscle weakness, or resistant to your calcium gluconate or insulin dextrose, acidosis that is resistant to your sodium bicarbonate, or uremic encephalopathy and uremic pericarditis. Right. That's all. Hope you got it. So good luck. You can come up with further questions in the group if you have it. Right. Thank you. Good night.